in vascular surgery fellowship. I have a master degree in vascular surgery, and I now I am a vascular surgery specialist. I'm just here to, join and learn from you. Not yet ready to take the OSCE, maybe. Yes.
Medical advice. You are happy to start?
Okay, Prof.
Okay, all right. So I show you the screen. You can see the screen now. It is a 75 years old lady with a background of chronic obstructive airway disease and the mild left ventricular left ventricle failure, underwent a mastectomy and axillary clearance for breast cancer 2 days ago by Mr. Browse. Post-operative, she developed axillary discomfort with shortening of breath and half a liter blood come out from suction drain or vacuum drain. The patient is due to go to home tomorrow, but for this complication, she will postpone. Her daughter want to take her at home. Her daughter want to take her in the afternoon to her home, which is 60 miles, about 100 kilo away from the hospital. Her mother and she pursued that it is her mother with best of her, and she spent, I as a doctor or you as a doctor spent about last 20 minutes trying unsuccessfully to explain to her daughter that the discharge today is not for the patient best interest, especially her home is away from hospital. The patient was keen to go to her bungalow. You know, bungalow is a countryside house. The daughter is very determined and wanted have own way. She is a school teacher out of home in morning. Her husband work also 2 10-age daughters or girls or boys in the school. Okay, so you can start. This is a bungalow. So, Dr. Matthew, can you start?
Okay. Good evening. I'm Matthew, surgical resident here. May I know who am I speaking to?
Yeah, I am Mr. Werberson.
Mr. Werberson, good evening. So, can I know that you are are you the consultant on call today?
Yes, I am the consultant on call today.
So, Mr. Werberson, now that you're on call today, I have a case. Today, this case is done by Mr. Browse, post-surgery for mastectomy and axillary clearance for breast cancer done 2 days ago. Now she developed axillary discomfort associated with shortness of breath and also...
what she developed in his axilla, you mean? What is this?
She developed discomfort over the axilla.
What it could be?
Okay, so what could it be? So 2 days post-op, I will be suspecting bleeding hematoma or probably lymphadenopathy.
Okay, so the most probably it is hematoma or seroma. Okay.
Yes, seroma.
All right.
All right. So, this patient has also underlying COPD and also with left ventricular hypertrophy. Okay. So now that she has shortness of breath and also bleeding associated around 500 cc from the drainage from the axilla.
Okay. So, Dr. Matthew, this patient is confident to make his own decisions. He has capacity to make his decision or not?
She is conscious. She can speak to me normally. So from those points, I will gather that she has the capacity to make her own decision. Nonetheless, I have been speaking with the daughter, and the daughter is rather persistent that the patient, the mother, to go back today.
All right. By the way, you mentioned they have something in axilla. You said hematoma or seroma, but you still have a drain. Okay. Yes. All right. So for this hemorrhage, just I need to ask you, what is your plan for this hematoma or seroma? What is the line of treatment you done already, or you need to do it?
So I'll go to A, B, C, D, E. Patient is speaking well, so airway is clear. Breathing, I check the SpO2, the respiratory rate, and then C, I'll take the vital signs, see the blood pressure, the heart rate, if patient is tachycardic or not, and then I'll also take blood. So FBC, I'll see the hemoglobin. If there's a drop, then there could be a bleeding that could cause a hemoglobin drop. So I might need to do something.
What is the indication to give blood transfusion in this patient?
If patient is symptomatic from the hemoglobin drop, as in tachycardic,
which level of hemoglobin usually we transmit the blood?
Generally, we'll give below 8 grams per liter.
All right. Okay. How to estimate the amount of blood loss?
So estimating the amount of blood loss, probably from the drain charting itself.
All right. So this is patient is have shortening of breath. What it could be?
Okay. Since this is 2 days post-surgery, there's number one, there's bleeding, swelling, so that could be pain itself. Number two, it could be a sort of chest infection due to post-surgery under GA, so she might have some sort of atelectasis from the lung causing pneumonia. The pain, and then she also has left ventricular hypertrophy, so it could be a cardiac causes, so might need to do an echo to see the heart function, and also X-ray.
What is the investigation you will do for her?
Okay, so blood investigation, HB, the routine renal profile, liver function test, electrolyte imbalances, and then I'll also go and do a chest X-ray, which is more relevant for this patient.
And is any more specific to see the oxygen saturation and all this?
Oxygen saturation from the finger spirometry, or if I'm suspecting a pulmonary embolism, I might need to do a CT pulmonary air angiography.
All right. So this case can be pulmonary embolism or not?
If it's 2 days post-surgery, it's unlikely unless she has some pre-existing condition like a previous deep vein thrombosis.
Okay, so what usually the time of pulmonary embolism to occur?
Pulmonary embolism would be probably after 1 week, around 10 days.
10 days, okay. All right. Of course, some patient presented by pulmonary embolism early, you mentioned, is bedridden or something like this.
Yes.
Okay. You have CT, you mentioned CT angio. This is a picture of CT angio. This is the normal. Usually, we can diagnose pulmonary embolism by it. All right. So what is a female, is this his daughter, is insisted to discharge or to take her, so what you will do?
Okay, first I will tell her it's against a medical advice, but if she does insist to bring the patient back, I will be telling her the warning signs to expect. So if there's increasing swelling over the axillary area, if the patient had the breathlessness is worsening, and also if the patient has discomfort.
Okay, but you already explained to her and she's not agree. So now what is your decision?
If that's the case, so I'm speaking to you now to ask for your opinion, and then after that, if the patient still insists on going back, then it will be discharged against the medical advice.
Any other advice or any other recommendation?
And then, of course, I will tell her all the early warning signs to look out for, and also to let her know to go to a nearby hospital, available hospital that is nearby her home, although according to her, it's in a countryside, a bungalow, and also to that she be aware about the early warning signs and to go to the nearest
so
hospital.
You have the list of the nearby hospital or nearby GP clinic, so you can tell her about that.
Yes.
Okay. All right. So all right. Okay. So suppose you are in the real exam, so you need at the end to do what?
Thank you.
No, before thanks.
Before thanks.
Yeah, I just put this picture just to remember. Maybe the other don't know.
Right. I will
summarize again. So you need to summarize. All right. Okay, and thank you. Okay, so back to the candidate. Thank you, doctor. So anyone have a comment? Any comment? After that, I explain in detail. So anyone have a comment? All right, so I just show you the detail again. So as we mentioned, this is phone call. This is a famous phone call. You see the screen. So it is just discharge patient against medical advice. As you see, this lady is old lady, have many comorbidity. And it is important to know this is operation done by Mr. Browse, but he speak to consultant in charge, which is another doctor. So he need to confirm first to him, as Dr. Matthew did, that it is not your patient. Of course, this patient is, her daughter is live away about 60 miles in Bangalore. Bangalore means a countryside. This is a picture of Bangalore, is a countryside house. So they usually in this area, they don't have big hospital, it's just a small GP or clinic. So what you do in this station, you enter, you have a phone call. So you tell, it's like Dr. Matthew say, I am Dr. Matthew, SHO or something, whatever your job. I speak to Mr. Wolverson or Mr. X. Yes, I am working in other firm and this patient is with other doctor, and summarize the case. Usually you have the case scenario in the preparation station and in this station. And after that, the examiner asks you some question from medical point of view. First, you confirm that it is a consultant in charge, and this is done already. You summarize the case, and he usually asks you about her daughter. See, first is important to have something called the capacity for taking a consent, or patient capacity. Patient capacity is this patient is adult, conscious, he understands the way, and in this patient she is okay, she oriented, she understands everything. So this is first, so it is important to know the patient capacity. After that, he asks what happened, what is this in axilla, so it is hematoma or seroma, and we can calculate the amount by suction drain or vacuum drain. What is your plan? Because this patient have hemorrhage, so I measure the hemoglobin. Of course, I can check the ABC if I wish. Of course, if hemoglobin less than 8, I give her blood transfusion. And just need to follow up this hematoma. Sometimes it's big hematoma, we need to evacuate it under anesthesia. After that, shorting of breath. So I will take a history, chest X-ray, arterial blood gases, baseline investigation. Can be pulmonary embolism? It is difficult because pulmonary embolism need to occur after DVT, so it take about 10 days. This is pulmonary embolism can presented early, yes, if this patient already bedridden for a long time, or in orthopedic operation, especially intramedullary nail or fracture big bone like fracture femur. After that, how can diagnose this pulmonary embolism? Usually diagnosed by CT, angio, or spiral CT. We show you the picture. Of course, in the picture in exam, they have no label, but of course you can find thrombus or something like that. After that, this is what we call the discharge against medical advice. So it is a special form in consent. So you inform the patient about the possible complication, maybe still bleed. It is not advised to discharge the patient who have drain. All this must be explained to her daughter and also to the patient. After that, you explain to the family, the patient and the daughter, that you are far away from hospital. You are bingo in countryside away from medical facility. The patient will be alone in the morning as her daughter is working and children in school. It is important to make a summary. What I show, this is grab food, is common in Southeast Asia, because usually if you order a food by telephone, they summarize the order at the end. Just remember, it is like KFC or Kentucky in some country. At the end, they summarize to the consultant. I try to ask the patient to stay, but she is afraid or refuse. So I have a consent for discharge against medical advice. And thank you, Mr. Wolfson. You thank the examiner, and terima kasih means thank you in Malay. Okay, so this is what happened in the real station. This station is 9 minutes. It is important to know that we have preparation station and have this station. You don't see the examiner. And the value of this all station, you need to confirm first that to whom you are speaking, you need to explain first, this is the patient, is not your patient, it is other doctor patient, but I call you because in the UK hospital, you speak the consultant in charge, not the consultant who do the cases. I know that in some countries they don't do that, but usually the consultant, if not in call, he don't answer the telephone or don't answer the call. Okay. So any comment, any question from anyone?
Hello, Dr. Sherene.
Hello.
I have one question about the summarization. So, should I summarize the case from the beginning that I just called the consultant and I
No,
explained?
not from the beginning. You summarize the important point. Like for example, it is usually when we explain to the student how mean by summarize, we just remind him that it is like when you order a food from any food application or from any site for food application. So they usually you ask him like that, but it's don't detail history. It is just the important. So the important in this case, I try to explain, but the daughter insisted to leave. So what I will do, I ask her to sign a consent discharge against medical advice. Just it is medical legal and for safety, and also it is important to give her the contact number of hospital and the contact number of ambulance or nearby small hospital, just if something happens. But you don't start it from much detail, but just at the end. Of
Okay,
course, yes. Of course, in some cases, suppose you have a presentation of abdominal aortic aneurysm rupture or critical situation, don't speak much. You start first by Dr. or Mr. Wilson, I speak to you about a case of rupture aortic aneurysm. I need, this is impending rupture. I prepare everything. I prepare the theater. I call the anesthesia. Everything is ready. We need you in the hospital. So this is the beginning. If it's very urgent case, and usually after that he asks you some detail because this is the exam scenario. So it is depend on the what is the
okay.
situation. Okay, so it is clear.
Yes, it's clear.
Okay, so suppose the patient have rupture aortic aneurysm, don't stay 5 minutes to speak to him, and at the end, this is maybe the patient died. So you can start by severity of the case and ask him, would you please to come? And after that, he asks you how to confirm what you do, how many blood you book, and others. Okay, I hope it is clear. Discharge against medical advice is a very common scenario in the exam. Okay. We have another scenario. The second scenario is it is how to refer polytraumatized patient to cardiothoracic surgeon or cardiothoracic consultant. Okay, anyone volunteer?
Yeah, I can volunteer if you may.
Okay, so I show you the script. So as you see here, a 35 years old man with RTA, road traffic accident, blood pressure is 100/80 millimeter mercury, Glasgow coma scale is 14/15, so it's okay, with left hemothorax, fracture left femur. You put a chest tube which drain 200 cc fresh blood at time of insertion, followed by 200 cc in second hour, the same in the third hour. You called cardiothoracic consultant to refer polytraumatized patient to him. Okay? So you can start.
Hello, my name is Dr. Muhammad Nabhan.
Usually in English culture, don't say hello, just say good morning or good afternoon. Hello, you can tell it to your friend.
Okay.
Okay. All right. Good morning
Good
or good evening. Good afternoon.
Good evening.
Yes.
My name is Dr. Muhammad Nabhan. I'm ST1 of the surgery.
What does ST1 mean? What does ST1 mean?
I think it's a core training.
No, core training is CT and ST is a specialist training. Okay, so we
Okay.
have okay, no problem. So it is different that what you call no problem. I will tell you at the end. Okay, after that, how to start is a station.
May I confirm that I'm talking to the cardiothoracic consultant?
Yes, I'm cardiothoracic consultant for today.
Okay, I am having a case with a trauma patient who have a
Okay, you see the
water
screen
failure.
now. Because you have
Yes,
the paper inside the room. So you have the patient. How old is the patient?
the patient is 35 years old man. Had a
Okay.
road traffic accident. He's
Yes.
vitally stable. Glasgow
So
scale.
can you tell me from the start how to manage this patient first? What is the management done before you call me?
Yes, I started with the Atlas protocol.
What is Atlas?
Airway. Yeah,
What
it's
is
advanced
Atlas
life
mean?
trauma support. It's advanced.
Okay. So what you will do?
I started with the airway, ensuring that the patient is talking air.
How to confirm that his air is good?
He's talking to me.
The patient talking to you. Okay. So this is A. What else?
Yeah, airway breathing. He was breathing, and I looked to his
So how
chest.
to check breathing?
I will look for his chest for the accessory muscles. I will hear the breathing sounds of him.
You hear or inspect, look, and percuss and auscultate first.
I will look.
Look. So you look, feel, and percuss and auscultate. Okay. All right. So in auscultation, what you found?
On auscultation, I found that the patient is having a left hyperresonant. It's hemothorax.
Actually, it
No,
is
no.
hemothorax. So it is
Okay.
left dullness is not hyperresonant. Okay. All right. So after that, what about C? What about the circulation?
Yeah, the circulation. I started giving the patient. I started with withdrawing full blood count from him. A full blood count. I started with the fluid resuscitation, and
So how to start the fluid resuscitation? What you put to start the fluid resuscitation?
two white.
Yes. No. I tell him we don't ask this. Only the student tell crisp, prof. This is a student believes that we like to mention crisp protocol. Actually, we don't ask about this. But the student insisted to tell that to us, but we don't know why. No. It is rubbish. No. Because it's something new, so it's not necessary for him. Okay. And the CRESP is mainly for critical ill surgical patient, usually terminal ill patient, not trauma patient, by the way. But it's no problem. Okay, so you mentioned, Dr. Nabhan, you mentioned that you have circulate, you give fluid. How to give fluid?
Yes, I will start with the two white bore cannulae for the patient.
Okay, what is the color of white bore cannula? What is the size?
Yeah, it's about 16 gauze French.
Yeah, you know the color. Usually the color.
The color is gray.
Gray or green? Okay, Okay, so you put two white bore cannula. What else after that?
Withdrawing a full blood count from the patient.
Okay, the blood investigation and the blood safe and
blood
group and safe.
investigations. Yeah, and blood clotting like INR.
What does INR mean?
International normalized ratio.
It is ratio between what?
I think it's between the BT and the BTT.
What is BT?
It's the partial thromboplastin time.
No. It is prothrombin time to control.
Time, I mean.
What is the normal prothrombin time?
I think it's about 0.15.
What is the unit? 15 what?
Seconds.
Second. Okay, so INR is international normalized ratio. It is comparison between prothrombin time and the control. Prothrombin time is 15 seconds. Okay, so you test ABC. After that, you mentioned that this patient have hemothorax, and you insert chest tube. Okay.
Yes, I will insert chest tube for the patient.
So why you call me? Why you need
because
to transfer the patient to me?
okay.
You can transfer him to he have a
to-
fracture femur, I think. You can transfer him to orthopedic team.
Yes, can I just look at the
Okay. Yeah, it is the main question. Yes.
yes, I think because the okay. Yes, because I drained to 100 cc of fresh blood at the time of insertion.
No, 200 at time of insertion, no problem. Okay, so the indication of the thoracotomy, you need to me to do thoracotomy for this patient or just to follow up the tube?
For those giving data,
Yes. They have 200 first hour, 200
yes,
second hour,
and the
200
same for,
third hour.
so
What?
it's more than 600 cc.
So you need from me to follow up the tube or to make thoracotomy?
I honestly don't know.
Okay. Any one of the candidate can answer the question.
Thoracotomy, because this is active bleed. It's been 2 hours, 200 cc over 3 hours.
Okay.
So it's
All right.
active.
So, doctor, you call me because you need to this patient to prepare the theater for thoracotomy. I show you later the indication of thoracotomy. So the indication of thoracotomy is if the patient at time of insertion, you have 1.5 liter at the time of admission, or if the patient have 200 for 3 successive hours.
Okay.
Okay. All right. So back again. So you make ABC. What about the abdomen? What you did in the abdomen?
I ordered a fast scan for the patient.
What is fast scan mean?
The fast scan is the focused assisted sonography for trauma.
Okay. For how many area you make a fast scan? How many quadrant or area?
It's for
1,
the
2,
9
3.
quadrants.
No. 9 quadrant is the abdomen, but in the fast scan is traditional done in 4 or 5 area. What is this area? Right side looking for the liver, left side looking for spleen, lower looking for free fluid, and for epicardium or epigastric looking for cardiac tamponade. Okay? All right. Suppose this patient have cardiac tamponade. Forget the thoracotomy. Suppose have cardiac tamponade. What we will do?
If he's a cardiac component,
Yes.
I think he need a thoracotomy.
No. Cardiac tamponade is pericardiocentesis, and this pericardiocentesis guided by echo or by ultrasound, and the patient connected to ECG. Okay. So you mentioned fast scan. Is a fast scan also can diagnose splenic injury? Okay. So you know what is the grade of splenic injury? Like 1, 2, 3, 4, 5 grade of splenic injury. Which grade of splenic injury you need to do splenectomy?
It's in grade 4. When there
Grade
is
4 and 5. Okay. So back to your patient again. So all right. So you mentioned can be bleeding, so we need thoracotomy. Can be this patient can be rupture or what's called it rupture thoracic aorta or
yeah. I
can
will assume that I will do chest X-ray for the patient, and I will see if there is
what happened in chest
mediastinum.
X-ray?
If there is a widening
Widening
mediastinum, yes.
Okay. All right. So, okay, because we have a time. So, Dr. Nabhan, can we start again? Just
Yes,
tell
sure.
me from the beginning. Started from ABC. Okay. So we can start now. So good morning or good evening. Yes, I'm consultant cardiothoracic surgeon. So you can start.
Hello, my name is Dr. Muhammad Nabhan. I'm ST1. So can I confirm that I'm talking to the surgical consultant?
Yes, I'm cardiothoracic consultant. Yes. So what you have?
Okay, I'm having a 35 years old male after road traffic accident. He have
Okay,
a
so what you did as a primary survey or initial management of this patient, can just tell me what you will do or
uh,
what you did?
okay. I started looking for an airway, which was patent, and the breathing, which she was breathing normally, and but I noticed that the patient is having a dullness on the left side, indicating that the patient might have a hemothorax. So I started with the insertion of the chest tube, which revealed a 2 cc of fresh blood at the time of insertion, and followed by 2 cc after second hour.
Okay, no, apart from this, after that, what about circulation?
Yeah, about the circulation, I started with the 2 pore cannula, ensuring that the patient have no other sides of his body bleeding. I started with 2 bore cannula. I took out from the patient a full blood count and a INR, and I start with the fluid resuscitation in form of 20 milligrams of crystalloids for each kilo of the
Okay,
patient.
all right. So why you called me?
Yeah, because the patient, there was a 600 cc of blood drawing from the patient in the last 3 hours. There were 3 successive hours.
Okay. Actually,
200
yeah, so you need to me for, so you call me for thoracotomy.
yes, I called you for therapy.
Okay. All right. So by the way, I just need to explain that if the patient after insertion have 1.5 liter, is indication of thoracotomy. If the patient have 200 for each hour, is not
Okay,
because not 600, but just if we have 200, 200, 200. So if I wait 10 hours, so he will lost his blood.
okay.
Okay. So I just review with you what we supposed to tell. So this is a phone call, again, calling for cardiothoracic consultant. You mean you need to ask him to transfer the patient for thoracotomy. And of course, you confirm the patient, you introduce yourself, you confirm that you speak to the consultant, you give him the quick history. Of course, he asks you about EBCDE, all this. And you tell him, I speak to you because the insertion of the chest tube and found this is 200 in successive 3 hours, which is indication of the thoracotomy. Can be ascending aorta? No, because chest X-ray, no widening of mediastinum. Usually in the station you have normal chest X-ray. Of course, check ABCDE, airway patent, speak, breathing is normal, looking, inspection, palpation, percussion. Can be tension pneumothorax. This is no tension pneumothorax. Why?
Because there is no division of the intestinum, no division of the trachea, and
Yes, no hyperresonant.
there is
Okay.
no hyperresonance.
All right. Okay. After that, you send the sample for cross matching and the safe. So you prepare blood. You send the full blood count, arterial blood gases. You put a chest drain, of course, underwater seal. Follow up the amount of the drain. You found it is increasing, so you call the consultant. After that, the plan of action of hemorrhage. So full blood count, check hemoglobin. If the hemoglobin is below 8, is the indication of blood transfusion. Inform anesthesia. Of course, I forget to tell you, you need to, before you call me, you inform the anesthesia, you prepare the theater. This is what happened in real practice. After that, we have fracture femur, we speak about it. And after that, summarize the case. And after summarize, thanks him. So back to original. Of course, you mentioned fast scan and ask you what is fast scan. So back again. So you mentioned that this patient have left femur fracture. So
Right.
what you are looking, how to manage this, and what is your initial management for this fracture? I know that you are not orthopedic doctor, but what is your opinion?
Yeah, I will use Thomas Bennett.
Just a minute. Dr. Muhammad, you have any comment? Yes. Yeah. Yes. Okay. CT is current training. Yes, and this, okay. Yeah. Uh-huh. Yeah. All right. No, actually, this is scenario is within the hospital. Actually, this hospital have a cardiothoracic surgeon. We don't transfer to other hospital. Okay.
Okay.
I just back to Dr. Nabhan of the fracture femur. Nowadays, we don't do Thomas splint, but when I ask you about fracture femur, so what is important for me to know as a general surgery or vascular surgery? What is important to know?
If there is no active bleeding,
What else?
for
Distal pulsation. Distal pulsation. So you must
okay.
tell him, I check the distal pulsation, dorsalis pedis is felt or not felt. So suppose another scenario, you don't feel the dorsalis pedis, you need to consult the vascular surgeon and you need to ask for orthopedic surgeon. So both can come. Of course, if this patient not done, you can put in Thomas splint now. Okay?
Okay.
For Dr. Muhammad question for transportation, this scenario inside the hospital, so it is inside same hospital. But if we speak to another hospital, you need to confirm that the ambulance is well equipped, the patient have oxygen in the ambulance, they have a doctor with him, and the distance between the ambulance or this hospital to this hospital is not far, so you have safe transportation of the patient. Okay. But in this particular scenario, it is within the hospital. I just to show you again about the femur. So what is supposed to be in the femur? Of course, I confirm by by X-ray for femur. I check the distal pulsation. By Doppler, it is palpable. I inform the orthopedic team. They put in Thomas splint till we solve this chest problem because they have a big problem now, which is chest. So we consult we just make something like first aid, and after that they can fixate it later because bleeding in the thorax or thoracotomy is an urgent operation. Okay. It is important at the end, as mentioned Dr. Muhammad Farouk, that it is I make a documentation in the notes, and of course it is important. Don't forget, before I call you, I prepare the theater, I call the anesthesia, and the nurse is ready. So it is important. And of course, if the patient have a family and I explain the family, or if the patient oriented, I explain to the family and the patient about the condition. Of course, this is urgent, not need consent, but you need at least to explain to the family. Okay, Dr. Muhammad, any comment, anything to add, or the student? Mm.
Okay.
Okay. All right. By the way, it is important before you enter the exam to know what is the indication of thoracotomy, what indication of admit the patient to neurosurgical unit, what is the indication of CT according to NICE guideline or the National Health Service guideline. Okay. Again, because Dr. Muhammad raised this point, CRISP protocol is a critical ill surgical patient, and it is usually patient in terminal condition, like terminal patient, cancer patient. And this is course and is not obligatory for you. It is important to know that white bore cannula usually is 16 or 18, and it is green or gray. And it is important because very common. Usually I ask this question, is a fixed question in my station. What is INR? It is international normalizing ratio, and it is ratio between prothrombin time and control, and the prothrombin time is 15 seconds. It is for follow-up oral anticoagulant, which is common use in England. It is different for patient on heparin, which is followed up by ABTT or activated partial thromboplastin. This is very important question because all the people in England, they usually they either on aspirin or oral anticoagulant.
Okay.
What in the station, it is important to know the notes you see in preparation station is present in front of you in the second station. So you can read it from it, you can follow it. Don't forget to ask for documentation. Don't forget to thank the doctor at the end. Don't forget to summarize. This is why we put this food delivery, just to remember how to summarize. Of course, just a quick, and in this situation say, so I will be ready waiting you in theater.
Okay.
Okay. All right. Any question? Anyone have station this before? Anyone enter the exam have one of this station? Still have about 15 minutes or 10 minutes. So anyone have the same station before? Okay. Yeah. Anyone have something like call to consultant a previous exam? You mean blue means that this have cardioversion or DC shock? Okay, so it is the same in Egypt culture, in ambulance in Egypt. They have, you can find two type of ambulance. One is the blue and one is red. The blue one is have cardioversion or cardiogenic shock and is prepared for monitoring of heart. But the red one, which is not common in most of the country, is don't have this facility. Okay, this is standard all over the world, by the way. Okay. What I see from Middle East, especially Middle East area, because they have no much in the communication skills, they don't at the end don't summarize. I attend many exam, maybe 70% of the student not summarize at the end, which is a common mistake. Second, most of them not thank us at the end, thank you for your time or thank you or waiting you or whatever. They don't do that. And again, in the beginning, as we mentioned, if you are CT, main core training, or SHO, mean you are still in training. But if sometimes they put you in a station that you are, why we put you in this small rank? Because one of the option of the answer is I will call the consultant because the patient ask you something is more critical. So I will ask my consultant. I will ask my senior. So this is to give you the chance. Sometimes the patient asks who did the operation. I don't know, but I ask my consultant, I ask by my team, something like that. So it is important to notice that again, CT is core training, means that core training is like SHO or resident. SHO is SHO, senior house officer. So it is like the first grade or first degree in the surgery ranks. Okay. Usually, if you tell him, the patient now have good blood pressure, the pulse is normal, we give him a blood, and I put a blood now for him, and he transfer, and the distance between our hospital to your hospital, usually it is about 5 minutes or 7 minutes. And usually the consultant or the second person say, so I wait him in the theater, I prepare everything, we will be ready. Okay, of course, transportation in England is fast, maybe because people respect the ambulance, so they can take 5 minutes, 6 minutes, something like that. It's not half an hour. Okay. Yes. Yes, yes, it's very common. You know that what I see in Middle East is the most of the communication skill station is usually is the main cause of failure in the exam, not the clinical, not the theory. Most of them are excellent in theory, in the examination of patient, but the communication skill is a big problem. And this is why, you know that in exam we have about 4 station communication skills, sometimes 3 to 4. So this is the main cause of failure or difference in the mark. All right. Yes. Thank you. No, Saturday we have a spine examination of the spine, and I forget what else. I think the doctor Iman he mentions that examination of the spine, so I can make, for example, examination of the neck with it. So can be 2 cases. All right. So spine and the neck, no problem. And the neck. Okay. All right. Okay. Thank you so much. Best wishes, and hope that you are did well. Okay, thank you so much.
Thank you for
so
your
much.
time, Dr. Sherene, and it was very important and helpful for all of us.
Okay. Yeah. Okay. Thank you.
Thank you, Dr. Sharon.
And
Thank you,
Thank
Dr.
you.
Muhammad.
best wishes.
Thank you very much.